Physiowebseries Neurological Anatomy Season 1. Let's begin with Series 5. In this series, we will discuss about myotomes. Myotomes, as the name suggests, myo means muscle. So, group of muscles innervated by single nerve root is myotome. Previously, we studied about dermatomes. So, there, as the name suggests, dermat means skin. So it was about skin, the single nerve root innervating the skin portion, and myotomes, as myo means muscle. So group of muscles innervated by single nerve root is myotome. So let's discuss about it in this series. Initially we have cervical myotomes. So if there is weakness in any part of the body or in any of the limbs, upper limb, lower limb, right, left, or the cervical portion, that is the neck. So, in that case, we can come to a conclusion that those myotomes are involved, as because of the disc pathology, the nerve is getting entrapped. So, if it is the sensory component, then dermatomes will be involved. But here, if it is the weakness which is the presenting symptom to the patient, which can be seen, so in that case, we have to know about myotomes, because the disc which is causing entrapment of the nerve, and that nerve is supplying group of muscles, certain group of muscles, specific group of muscles, which are causing certain actions. For example, shoulder abduction or elbow flexion. So if the patient is not able to perform that particular movements because of the weakness, then we need to test for cervical myotomes by resisting the movements as shown in those diagrams. So let's see what movements are associated with what myotomes. So let's start with cervical myotomes, starting from C1 to T1. So C1 and C2 both are for neck flexion, also sometimes considered for neck extension, but mainly, as you can refer this part in Maggie book for orthopedic physical assessment, so you can refer it there. So now let's continue. For neck flexion we have C1, C2. So we can check for neck flexion by providing resistance this way and ask the patient to perform the cervical or neck flexion and check the strength based on MMT grades. So if the patient is not able to perform because of weakness, then we can think of somewhere over here the C1, C2 nerve root is entrapped. The motor component is responsible. So C3 is for neck side flexion. Along with C3, cranial nerve 11 is also responsible, which is the accessory nerve. So is also responsible. Now focusing on just the nerve roots, spinal nerves emerging. So for C3, it will be side flexion. Can be appreciated in this diagram how it is tested. So side by side, we are also keeping the clinical aspect, that is how to test those myotomes, because it is as simple to understand. So this is about C3, neck side flexion, lateral flexion. Next is C4 for shoulder elevation. You can see the resistance is this way and patient is asked to elevate the shoulder. Then C5 is for shoulder abduction, can be seen in the diagram. Now C6, we will see the diagrams further. So C6 is for elbow flexion and wrist extension. Opposite of this will be in C7, which is elbow extension and wrist flexion. So the C7, to remember it easily, you can imagine or just keep in mind the position of the upper limb while riding a bike. So as here an animated image has been shown to demonstrate or to remember C7 myotome, C7 cervical myotome. You can see the elbow is extended while riding bike and the wrist is slightly flexed. So considering that, we can remember To maintain the distance, generally we can see elbow will be extended and wrist will be slightly flexed. So we can remember C7 myotome as bike ride position for the upper limb. So just making easy to understand and remember. Elbow extension, wrist flexion is for C7. Then thumb extension and ulnar deviation is for C8. Along with that, C8 also has finger flexion component. And T1 is intrinsics of hand, which will include finger abduction and adduction. So here we saw till C5, neck flexion C1, C2, then neck side flexion C3, shoulder elevation is C4, shoulder abduction is C5. Continuing with C6, how to test or how to resist the movement. So C6, those two we can see. Elbow flexion is being resisted here and wrist extension is being resisted here. Same way C7, which is opposite of C6, which is the bike ride upper limb position in bike riding, can be remembered, where the elbow is extended, and wrist is flexed. So that will be C7. So to remember it easily, we are using this as mnemonic to remember. So C7, we have this elbow extension resisted and also wrist flexion resisted. Continuing for C8, it is thumb extension as well as finger flexion. Then T1 is for abduction, adduction of the fingers, which is intrinsic muscles of hand will be tested. So that is about cervical myotomes we discussed right now. Now there is one thing to know, that thoracic region myotomes, we don't test it because practically the disc which are present in thoracic region, they are not responsible to generate this weakness. So there are some other reasons why the weakness of certain parts are present. There is some other pathology behind it. So as discussed over here, disc lesions at upper two thoracic levels, as mentioned over here, they do not appear to give rise to root weakness, weakness of intrinsic muscles of hand, which is finger abduction, adduction, which for T1 we considered and tested also, but including that, even including that T1 part, T1, T2 and T3 to T12. So if we consider that intrinsic muscles weakness of the hand, that is due to some other pathology. For example, it can be due to thoracic outlet pressure, neoplasm of lung, ulnar nerve lesion, etc. And one more thing to note is that T3 to T12 also, weakness is not detectable. That is, this articular and dural signs, they are, and the root pain are common. Cutaneous analgesia are rare, so they have little localizing value, so they can't be tested, or we cannot rely on this. So thoracic myotomes will not be there. So after cervical region, we will straight away move to myotomes of lumbar and sacral spines, starting from L2. So L2 is for hip flexion. You can see over here the hip flexion is being resisted. Then L3 is for knee extension. You can see over here. L4 is for ankle dorsiflexion, resisted over here. Then L5 is for grade 2 extension, resisted over here. S1 is for ankle plantar flexion, which is not shown over here. It will be opposite to this L4, opposite to as shown in this diagram. Ankle plantar flexion will be there. Then ankle eversion can be seen. Ankle eversion of S1 can be seen over here. It is resisted. And the hip extension component of S1 can be seen over here. Similarly, S2 will have knee flexion, can be seen resisted over here. So some positions and how to resist the movement. to test for myotomes of lumbar and sacral spine. So now one more thing, how to easily remember myotomes of lumbar and sacral spines. So based on the action, we can remember the myotomes, because to test those myotomes, we have to resist particular action. Suppose hip flexion. So if we are resisting hip flexion and if there is weakness that we found out, then possibly L2 is involved, L2 myotome is involved in that case. So we need to remember. So to remember it easily, you can rely on this diagram. So this position, if we see, this is for remembering L2, L3, L4 and L5 myotomes, where the hip joint is flexed. Hip is in flexion. Can be correlated over here. So L2 is for hip flexion. The knee joint is in extension. Knee joint is in extension, which is L3 myotome action. And then this is ankle, and ankle is in dorsiflexion, which is L4 myotome, and great toe is in extension, which is L5 myotome. So in this way you can remember hip flexion, knee extension, ankle, dorsiflexion and toe extension for L2, L3, L4, L5. So going down, you can just consider one joint, hip, knee, ankle and toe. So hip flexion. So this position itself, you can just remember this diagram. Hip flexion L2, knee extension L3, ankle dorsiflexion L4, toe extension L5. Easy way to remember. Now S1, S2 is remaining. So S1, so at the hip, what is S1 doing? What is S1 responsible for? S1 myotome. So it is for hip extension. We can see here hip extension can be seen. So it is this position. So this position can be assumed to remember S1 and S2 myotomes. So hip can be seen in extension, which is S1. Now knee is flexed. It is for S2. Again going to ankle. So ankle is plantar flexed, which is for S1. Along with plantar flexion, there is eversion component to be remembered extra. So S1 is hip extension, S1 is ankle eversion and plantar flexion, and in middle we have knee joint. So knee flexion is for S2 myotome. Again can be discussed on this diagram. So hip extension is S1 dermatome, then knee flexion is for S2 myotome. Sorry, hip extension is for S1 myotome, knee flexion is for S2 myotome, and again coming back to S1, so ankle joint, so ankle plantar flexion as well as eversion is for S1 myotome. So here only in center for knee joint S2 is there. In sacral myotomes, for sacral spine region, we have S1 at the top and at the bottom, and in the center for knee joint we have S2. So we can just remember this position where everything is going back posteriorly, and hence we can just assume it and remember for hip extension, then knee flexion and ankle plantar flexion plus eversion. So that's it to understand about the myotomes. So we have finished cervical and lumbar myotomes to be tested if there is any kind of disc pathology which have been covered in last series, series 1 2, so it will be understood better from those series how disc pathology or the vertebra pathology can cause nerve entrapment, and if the nerve is involved because of the disc pathology, then the nerve which can have sensory and motor component, if the sensory is affected, then dermatomes will be involved or affected, which we can test, we physiotherapists can test for it. And if motor component of the nerve is affected, so it can cause weakness and myotomes will be involved, so we can test it accordingly. That's it for this series.